Probably not, because we were muted, right?
Wait, are you ready whenever?
Okay, we can hear you now. Thank you.
Yep. We're recording.
That's okay.
Okay.
You did say that.
But you amend the transcription when you have.
Sure. Okay, I'd like to call to order our Board of Health meeting for January 26th. We'll start with, let's see, roll call. We see we got Toby's here. Present. Signed in, present.
Yep.
Okay,
Yep.
Kim? Josh, present. Okay, and Louis there, okay. So we got four, right? We have enough for that, right?
Yep.
Got everybody there? Good, okay. Next, to approve the minutes.
So moved.
Second.
All in favor? Opposed? Passed. Okay. Now, public comments. Do we have anybody that would like to speak here? Anybody here? No, everybody's all set there. Last time, anybody here in the public like to speak? And then how about on Zoom? Anybody on Zoom that'd like to speak? About anything about our agenda or anything that has anything to do with the health board?
There's a hand raised.
There's one, right? Is that Connolly, I think?
Yes, that, if you can hear me, Supervisor Heron, it is Conley, District 26.
Good, thank you. Did you want to speak?
I do very briefly. May I proceed now?
Go ahead, thank you.
Thank you, Mr. Chairman, and to the entire committee for the opportunity to speak with you. A few of the members, several meetings ago, had requests of me, and I would really like to provide an update that I do take very seriously my role as a supervisor, and I continue to open dialogue with all committees, commissions, and board. And as per some of the requests, I am currently attending Wisconsin's public health laws in preventing and controlling communicable diseases. An absolute wonderful set of seminars. Number 2 of a set of 3 has just concluded. Personally, as you know, I have a passion for research, and this includes ongoing, continuing to research DHS Code 145 and Chapter 252. And I continue to also research personally infectious diseases, transmission, and abatement. Mostly, though, what I wanted to speak about was some very disheartening exchanges that followed the vote at the last board meeting. And please allow me to reiterate, first and foremost, my total admiration and gratitude to Ashley Romlow, who has been absolutely phenomenal in answering questions, presenting research, and being a formidable person in helping people that need help in our county. Unfortunately, though, for some reason, there were some mischaracterizations and cheap shots. Now, I'm speaking only for myself, and one of the things that I heard, this had absolutely zero to do with being Democrat, Republican, Independent, or Libertarian position for me. I really hope that my voice has been one of the loudest in the county in obtaining the TrueNarc unit, which detects illicit devices so that people are not harmed. I was also one of the loudest voices to put back in the budget resources that were stripped that would have aided the MEG unit. Now, where I agree with our Deputy Chief Christofferson and Supervisor Defferting, that you cannot arrest your way out of a problem. The reason that I was so aggressive in going back after these funds and supporting the MEG unit was to get some of these substances off the street and out of the hands of people in Winnebago County. As far as the vending machines that were spoke about and appears to be on your agenda, it is not the machines themselves, it's the method of delivery that is giving me some pause. I do want you to know that I am currently working on what I think is what Dr. Smiltnick brought up in an email, I think to all of us, to absolutely carpet bomb this valley with the Deterra kits, fentanyl test strips, and Narcan. I really hope to be able to work in conjunction with your committee in getting that all over this valley. That is something different than the machines, but not denying someone that wants Narcan fentanyl test strips or the Deterra test kits at all. I really, I just want you to know it was not political for me, not at all. And that was said, and that was really disheartening to me. Thank you so much for your time.
Thank you. Is there anyone else on Zoom that'd like to speak? That's the only one. All right, on to business then. Doug, you want to take this one?
Sure, yes, I would love to introduce our newest board member, Kim Lou. Maylock, get it? Only I started, it took me a while too. And it would probably be helpful for everyone to introduce themselves, but Kim, if you wouldn't mind, just saying a few words about yourself, how you came to, commit to being on the Board of Health, what your experiences have been that brought you here. Really appreciate that.
So I've been in Oshkosh, close to 10 years. Our family moved here. I work currently at Ascension as a director of clinical programs. A year ago, I received my master's in public health from Medical College of Wisconsin. So I was really looking to get a little bit more involved in public health.
Okay, thanks. And then, yeah, if we could just go around,
Sure.
mostly staff and supervisors here. So Kim and I spent almost 2 hours together about a week or so. So Doug Garrett, public health director.
Hey, Corinne, the supervisor for District 5, which is Nina, Doty Island, and just a little bit south of that. I'm here because I am finding this absolutely fascinating. Back then, I did my nurse's training. In by profession, mother now, wife, grandbaby. Well, married to a dermatologist who's retired now. He worked for Doug Horan.
Toby Vanden Heuvel, I'm a citizen member, been a citizen member for the last 3 years. Engineer by education, I do have a year of nursing education. My wife's a doctor, I'm a volunteer nurse, and just very passionate about.
I'm Heidi Keating, I'm a public health planner. I have about 15 years of public health experience and just got my MPH from Medical College. Yeah.
Lana Erickson, I supervise the Healthy Lifespan Division. I've been here about 8 years and got my MPH over the class.
I'm Jackie Greenham. Unusual spelling, so it's J-A-C-I. Don't ever see it. Didn't choose it that way. Clinical disease supervisor. Worn a lot of hats over the years. Cardiac down at St. Lucie, Milwaukee, surgery, school nursing, and
I am Boyce. I'm the environmental health supervisor. I've been in public health for almost 40 years.
wow.
Maybe 4 years.
Hi, I'm Ashley Romlow. I'm the Community Health and Prevention Supervisor. Kim and I got to meet each other a couple of years ago when she did a practicum with the health department.
I'm Lois Ritzmacher. I'm a retired public health nurse. Started at the city of Oshkosh. Eventually came to the county, Winnebago County, and then popped up to Outagamie County. And was public health nurse coordinator, supervisor, and acting health officer for a short time.
Cool. I'm Ralph Harrison, District 31, that's your district. And I know your husband from the herd, hanging around with you guys there, so welcome. I was in the car business for 50 years and decided to get back, and so I got involved in doing a lot of community stuff, and I wanted to get into health department stuff. I do the farmers market, so that's where I got hooked up here, but celebration lights, I just do a lot of activities. So they've had you involved, so welcome aboard. Thank you.
I'm Josh Belleville. I'm in District 19, which is this entire neighborhood here. I'm a doctor of chiropractic and I'm in sedentary practice. And I really enjoy health and wellness, and this kind of fits into that. So very excited to have it. And to have you too.
And I'm Karen Powers, District 25, which is basically West Haven area in Oshkosh. Been on the board for 8 years, and I've been on the county board for 8 years. Here just a couple years. And my only medical thing is that my granddaughter is a nursing student at Marquette University.
I'm Belinda DeLuey. I am a public health nurse, and my current role here at the health department is I'm the program manager for the WIC program, and I've been here for 35 years. In March, it'll be 35.
I'm Shelley Brown, I'm the preparedness specialist, and I've been here for 4 years.
Well, then, get one more board, yes, yes. I guess next would be the income statement.
Yes, you have two versions of an income statement in front of you. A single pager that Sarah Jean, our epidemiologist, puts together that just helps simplify where we're at. This is a year-to-date statement. You could also call it a year-end statement, but the books really don't close until about March. But this gives you an idea of where we're at with budget. For Kim's benefit, typically our revenues lag behind our expenses a couple of months, sometimes more, depending on what the funding source is. More than half of our funds come from non-levy sources. So lots of contracts and grants, fees, and those all come in at various times of the year. In our current budget, for 2023, we budgeted roughly, and you can see here in the adjusted budget, we budgeted a deficit of about $759,000 or $760,000. That deficit, it was budgeted to use public health reserve funds. Public health department has its own reserve at the end of the year. Funds from the public health department that are remaining, we close out to that fund. That fund is currently about $2.5 million right now. And so if we expended everything that we anticipated or budgeted for, we would reduce that reserve fund by about $800,000 or $760,000. As of the running of this report, you can see that we're actually, our year-to-date actual is a deficit a little over $1 million, which is, $300,000 more than the deficit that we budgeted. However, Bev, our accountant, ran the numbers for us, and we still have, probably a little over $1 million yet to be received in income. So we'll actually probably not use a whole lot of the reserve fund at all, because, right now, if we take that 300,000 that we're short and take $1 million off of that, or add $1 million to that, we're roughly 700,000 under, which means that we're actually under what we budgeted to spend, and we'll probably won't expend as much of the reserve as we had actually planned to. So that reserve will stay a little more funded than we'd actually planned at the beginning of the year. So bottom line is, I know that sounds confusing, is we're doing better than budget in terms of our revenues, and we'll have expended less dollars than we originally budgeted. So we're pretty healthy. And for 2024, the budget is fairly similar. There's actually a larger amount that has been put into the reserve or pulled from the reserve, adding to levy. I want to say it's about $925,000 that has been targeted to be pulled from reserve in 2024. You have the multi-page document is the detail, and I'm happy to answer any questions about the detail. Mostly we're just concerned whether or not we've stuck within our budget. Yeah.
If I can, mostly information, but as supervisors now, we're starting some kind of training. We just started where we're going priority budgeting, which I don't know if anyone knows that's going on now, but we had a couple of meetings where it talked about it. And I don't know if this is the time to talk, but it'd be interesting to see, again, we see what they tell us about what we're going to do and what they're set up, but it's always how it's gonna affect the health department. How you guys are budgeting, how it's gonna affect you. Because with priority, it seems like 1 to 10, which is important, which isn't, so that, to me, that something might not be pushed through unless somebody really backs it, really pushes for it. Sounds like what they're doing. But we should probably have a discussion on some time, I would say, or how you guys feel, health department, or what areas are important to you. So we don't wait until the last minute and then say, okay, well, we didn't know that, we didn't know that. That's just a suggestion. Anyone else have thoughts on that?
Well, interesting you brought it up because I've got written down here priority based.
Yes.
With a question mark behind it. I was looking at this and wondering if, because this is simplified some, if this is working towards that priority based budgeting.
It's really just meant to condense this, 4-page document down to something that's a little bit easier to read, with this rolled up into the categories. In terms of priority-based budgeting, that the county kicked off last year, there's currently, and I actually meant to put a plug in for this before, there's a survey out right now for county board supervisors to fill out. It sounds like maybe about half of the supervisors have filled that out so far. The finance department is really encouraging supervisors and department heads to fill that survey out to, help define what are the services that county board of supervisors, at least, and department heads, feel are the most appropriate and services, and with what kind of priority they have in terms of whether or not the county should be providing that service or not. And there's a defined list of categories and a defined list of services. There's room to add additional information if you feel something is missing. But certainly, reviewing that tool and filling it out is, maybe will help the process.
Right.
I'm not sure I can call it strategic plan.
No, but I just wanted to be able to discuss it, so we know, because when we went through it, and when I was there was like 16 of us, the first 16 that went through it. It was interesting. You did the survey, some people did it in 15 minutes. I took me 2 hours because I had put so much thought into it. I don't think, and then as we get going, the discussion was 2.5 hours. Because they talked about everything differently from what you think and what I think. Just for example, road repairs, okay? We thought that was transportation and safety. No, it's a county government, what we should be doing for the services. So we were thinking like buses were more, and the city takes, so I mean, it's really important, so I can see us going through it, doing it 16 minutes and then doing a longer time, that really discuss to know exactly how you feel. Because as supervisors, we're gonna give categories that we think are important to us, but when it narrows down to the long list of stuff, what is important and what isn't? We wanna know your feelings. I mean, I think the budget before, here it is, we went through, we picked 1 or 2 things out, but we spent 3 days doing it, right? Yes, fine. So I feel that we should get more of your feelings and what's important to you guys. Because when we're going through the budget, you produce it, you talk about it, but it's important for us to fight for what you guys feel and what we need to do. Is there something that we're neglecting because the list says it's not on that one, it's number 1, and then there's one that's 10. Should we cut that one out or not? You know what I mean? Well, we won't know that. I mean, the supervisors, it's what we think our constituents are, but it's not the feeling of what we want here. That's all I'm saying. That's all I'm saying. Right?
And what I found in going down the list, as you go down that list, your thought processes change. And so if you change your priority, lo and behold, if you've got to figure out where you now have a gap to fill in that gap with the number. And so I found it was time consuming.
Yes.
Absolutely it was.
But the one strong part I thought was really good. Health, human services was up there and everybody's real tall. So,
yeah.
So that was good. Very good. Again, just wanted to bring that up. It's in there if you didn't know about it. So you get to know about it, and we should talk about it. It's okay with you guys, what you think, right? But we got comments.
It's going through that training as well, or is it just?
I think so, right?
The department heads were asked to fill out that tool. And I've asked if that is gonna be expanded beyond that, and that hasn't been decided yet.
Okay. I mean, you're not your budget as far.
No, well, it's all related. I mean,
Okay.
we could spend additional time at a future meeting, really going through all of the revenue sources that we have. 'Cause, I mean, an income statement doesn't translate into programs, right? It just shows expenses, in a kind of a standard way. But it doesn't really show where the money is going in terms of programming. And we could spend a little time, going through that org chart again, going through the program areas, and then just giving you a sense of level of effort that we have. There are some areas, of public health that we don't have funding to invest, and there's areas that, we'd like to do more work in. Chronic disease is one of those, chronic disease prevention. We really don't have resources to do that. So it'd be one area that, we're continuing to look for resources in. And then, unfortunately, money flows very categorically. When you have a pandemic, you get lots of money for communicable disease. We're in an opiate crisis, so now we're getting money to deal with that. We try to take advantage of those funds when they're available and apply them the best that we can while we have them. It's not a great system. It's always after the fact. Public health, in Wisconsin is not funded well. We're number 49 or 50 in terms of the amount of funding per capita that's actually put in place here.
450 in the state
In the
or in the, okay, nation?
Yeah, so Wisconsin is one who invests one of the lowest amounts per capita in the entire country. And our outcomes are a little better than that. But yeah, we invest much less. So it is, we are limited in what we can do. We did go through a process, recently looking at what all of the foundational public health services are, where we would hope to be in the future. If we could build the department today, right, to address foundational public health services in areas that we think are the most important, what would we need to do that? And we identified, I think it was like 12 or 15 positions that we would just add tomorrow, start working on a number of issues, to be, considered, average funded and being able to actually address all of those foundational public health services. So, we can bring some of that information forward that'll, help you understand where our challenges are. And you can help us prioritize, what we choose next.
Okay. Okay, I just want to bring it up, just want to make sure everybody kind of vote. You'd be interested in that, is what everyone? Okay, all right, if you could,
The priority based stuff, is so subjective. It seems, I don't know how you categorize. It's not like the county is providing anything like party planning. I mean, everything the county provides is necessary for the citizens of our county to survive. And, if I were to take this completely subjectively, I'm on Social Security. My youngest grandchild is 15. Why should I care about WIC? But obviously we have to care about that because there are women, infants and children who are nutritionally disadvantaged. But again, if you've got people who are only looking at what's good for, what's in this budget for me, a lot of things are going to be overlooked. That was one comment that I had about that, but I was also going to ask, and I'm used to looking at the human services budget where you might provide a service in 22, you don't get reimbursed anytime in 23. You're doing a budget for 24, so you're budgeting for something for money you've already spent. And then sometime mid 24, the whatever you provided in 22 is finally getting paid. And so here's this money that you didn't know was coming, and you didn't know, you expected it to come at some point. You didn't know when, and you didn't know at what percentage it might come. And you can't ask because they said, we can't tell you how we figured this out. They just do not tell you. Do you have that in public health as well, where you can provide something over the course of that funds over the course of 3 budget times before you're actually reimbursed?
Not typically.
Okay.
There have been instances where, like for prenatal care coordination, we would provide services, we bill MA, we would demonstrate how much less we received than our services actually cost us to provide, and then get a reimbursement. And that could be 2-3 years down the road, but typically it's not to the extent it is in human services.
Okay.
And, with like WIC, it's a good example. You know, even if WIC didn't fall on a high priority level in the county,
Mhm.
it's fully funded from the feds, 100%. We don't spend any levy money on WIC. And so because it's a program that's so necessary, and it's been in place for now for decades.
Yeah.
It's like, so it may not score high, but that doesn't mean we shouldn't do it. It's fully funded and it's good for the community.
Yes, it is. Okay.
Well, and what I find interesting is that in the survey, as you're going through it, what you don't know is what is mandated.
Right.
And that is something else that needs to be addressed.
Yeah, I think that'll probably have to be next steps. I mean, what's mandated and what's, you know, funded, right? How many of those are unfunded mandates, that perhaps pull funds away from someplace else? And how do we get those mandates actually funded from the institution that mandates them to begin with? So like the state in this case for most of our programming. The priority-based budgeting, I agree. Ralph, it took me a while to get through it. There's no definitions for what the categories are. So until you really start having a discussion with the consultant, it's tough to know what fits where. And then it's always hard when you're given a list of choices to be like, well, what's missing from this list, right? And there are things that are missing, you know, from the categories that are there, or you don't realize they are in a different category. So
That's where Karen brought that up. It's important that I'm doing this, we're advocates, we're ambassadors for the health department. We're gonna have to bring knowledge to them, because if the supervisors are here or visiting or retired, they're not gonna know about it. So for us to kind of have an idea in the next 3 to 4 months, what is priority, what is important, we can talk about it, because they'll ask us a lot of times. The last couple of meetings, they can write out and ask somebody from a board, tell me about this before I decide, because they have no idea. So that's why I thought it was important, like you said, they have no idea, but if we have it, we can at least have the information, say, oh, that, we need to fight for that, we need, that's important. So that's why I'm really brought up, okay? Good.
I think it's important that it was brought up.
What?
I added that discussion to our
Okay.
meeting minutes, so it's noted to put that on
Thank
the
you.
future agenda.
Okay. All right, anything else on that, on the budget, or?
I just have one clarification question with this all here. It seems as if we're trying to zero out the reserve fund. If we took the money last year and this year, is that?
yeah, the intent isn't to zero out the reserve fund. The intent, with the reserve fund is that we substantially increased the amount that was in the reserve fund during the pandemic. Mostly because we received a lot of funding to respond to the pandemic. And we just didn't have the capacity to add people. I mean, we pretty much, with all hands on deck, a lot of our staff that were being funded by levy or another program source, ended up being funded by COVID funding because that's what they were doing. And so if they were funded by levy and they were responding to COVID, we charged their time to COVID, and then we just saved on levy, and that we ended up with surplus at the end of the year because we didn't spend our levy, and that went back into our reserve. And so what we've been doing is applying a fraction of that reserve, a large fraction, but we don't really need to maintain the balance that we have. When we apply that reserve, it lowers our levy, it lowers the tax rate that we're charging citizens for public health services. So that can't last forever. And it does, when you look at the budget overall and you see what the levy is for public health, it artificially lowers our levy, or at least what it looks like our levy is, because our levy, you know, for this year and for last year is roughly, you know, 1.8 million. We're applying 800,000 of reserve. Our levy is really 2.6 million. And when, you know, when we get to a point where we, you know, can't pull from that reserve fund any longer, it's going to look like there was a huge increase in public health expenditures from a levy perspective, when there really was no change. We were just pulling from another source. So that there'll be a difficult discussion down the road, you know, when our levy appears to jump up by 40% or whatever it is.
Gotcha. I always think of that same thing with the services, when they have that extra money. You made a comment just a little bit ago that if we could, there's 12 jobs we could use right now to do this. And then you think, well, we got $1 million. You know, it's like, well, why don't we share it and use it? It's ours, you know,
But
from
it's
a health department.
yeah, The
Doesn't
labor is a
work.
recurring expense,
I know.
right? And so we could spend it, hire people for a year and then not have money next year.
Okay. Well, just important stuff to know that, right? Well, thank you, guys.
Thank you.
Next would be C. This is the update, you're gonna need update, but I just wanted to make a little comment about, I wanted to put this on here because I think pretty much, as far as I know, everyone in this room is for having machines. I don't think there's any debate that where there's somebody that doesn't want machines. It's just that, again, with the real close one person off type thing, we need to look at what we can do to maybe improve it or bring it back with something else, changes. And I just wanted to hear your updates, but maybe just talk about the things that we know as supervisors that we needed to change, so maybe we could get this brought back. Yes, sir.
I don't know if you're gonna make a whole, I think there was far too much discussion on that grant about where it's gonna be. It's gonna be too close to where kids are and all. I thought, stop messing with those discussions. Let's get this money, approved and then figure out later whether it's gonna be near the YMCA or, you know, those are the things we can hash out later once we accepted the money. The other thing is that a number of supervisors kept talking about, you know, this is taxpayer money. It was never taxpayer money. The grant came from the opioid settlement, but it wasn't it wasn't the opioid settlement we already agreed to, because I thought I had contacted Mary Ann and said, since we've already agreed to accept the opioid settlement, doesn't this fall under this? And she says, no, it doesn't. It's additional opioid money. There's not a single dime of taxpayer money in that $80,083. They came out of the taxpayer's pocket. And frankly, even if it had, if we turned it down, it's not gonna turn back into anybody's pocket. Once you've been taxed, it's not like you're gonna get a tax refund because someone turned it down, but it was not. It was opioid settlement money. We deserved to have it. They owed it to us and we were silly. And yes, it was only off by one. I hope it gets brought back up again. But not spend all the time. Is it gonna be a line of line? And remind people, this is not taxpayer money. This is opioid settlement. We got this money from abusive practices, by punishing abusive practices by pharmaceutical companies, not taxes.
Well, Doug, why don't you bring the update first? That one.
Sure, yeah, I put this on the agenda, just so that people knew we were gonna have a discussion about it. Wanted to hear your reflections on how this went. Also talk through with you what our options are for moving forward and, you know, and where this fits in our overall opioid response. And, you know, I guess Karen probably started in a good spot. These funds became available, through the state, through opioid settlement funds. The state in 2023 allocated about $2 million for public health vending machines specifically as one of many strategies that we're looking to do to reduce the impact of the opioid crisis. That opioid crisis has evolved from, you know, prescribing practices, you know, or maybe misprescribing for pain, misleading by manufacturers, enabling by retailers to, you know, have opioids prescribed in people's hands that, you know, that were initially deemed to be not addictive, certainly are addictive, and, you know, we're living out the consequences of that now. Fentanyl has completely changed the game with that. And so we continue to have an opioid crisis, you know, now that has really moved into more of a synthetic product production that is extending the crisis that we're in, and it will likely extend it for many years to come. We competitively applied for these funds with the state. And so we were one of roughly 30-ish organizations, mostly public health departments within the state, that received the funds. We actually had our request decreased. We had originally planned for 3 machines. We would have applied for more even than that, but it was what we could put together with our community partners at the time. Ashley and her team did a great job putting the grant together. The state came back to us and said, hey, we want to fund you, but would you take less? And we certainly agreed to do that because there was so much demand across the state for this. The intent here is to distribute naloxone. We know that the more naloxone that's in the community and the more it's available, the more potential lives that are saved. And there's plenty of data and evidence to support that naloxone does save lives, but it has to be in people's hands first. Public health vending machines are not meant to be like an AED machine, an emergency response sort of thing. You need to have these materials in your home. This is one of multiple strategies of getting naloxone out into the community. We currently give naloxone for free at the health department, but you have to come in to the health department to get it. And you have to come in during our office hours to get it. We've partnered with Solutions, and Ashley can just jump in here anytime you want. We've partnered with Solutions on distribution of Narcan. I think what people probably don't know is that, Solutions has already placed 20 nalox boxes out in the community where Narcan can be obtained for free. It's not a vending machine, but it's a place where you can just go and open a box and take the Narcan. There are other locations, a handful of other locations within the community where you can receive free Narcan. But just having, a limited number of free Narcan locations doesn't mean that Narcan actually gets into people's hands. Coming to the health department, it takes a commitment. It's like one place in the community. There's stigma associated with substance use. People may not come in, may be reluctant to talk to somebody, but if we can save, them from an overdose, we can talk to them tomorrow, hopefully. And so this really is just one of many strategies to get more naloxone out. We've had a conversation with the Department of Health Services related to what our opportunities are to do with this funding after this. The state is open to extending the time frame in which we could use these funds. The state is also taking a look at some other options for us. Is it easier for us to divert this funding to a community partner and just have them do it instead? If we can't have agreement on the county board that this is enough of a priority to move forward, do we delay to another point in time and then try again? Our goal is just to get the naloxone out as quickly as we can. Public health vending machines, it's just a different way to do it. And it also, provides opportunity in the future for distribution of materials, that the community feels is necessary, for supporting our community. And that, that may not be even a request from us. That might be a request from the community partner that says, hey, you've got a couple locations, we want to get these materials out. Can we use, your method of distribution to help get those materials out? Right now, it's just about naloxone and fentanyl test strips. That's really what we want to get out. Ashley, I don't know if you want to add any more to that.
Sure. So I think, first of all, just a couple of things that I want to share with you all is we did have that meeting with the state yesterday. And the state representatives are people that have worked with our health department for a really long time. And some of the first things that they really complimented us on is the just amount of things that Winnebago County Health Department has done to try to minimize opioid death and overdose death. And they just had a lot of really great things to say about this health department's work. And they were really complimentary of all of that educational material that you guys have seen that we put together. They're using that in other places across the state as well. And a big kudos to Madeline Brigger, who really wrote this grant and has as you likely recall, we turned in this grant in April of 2023 and we were granted it in May of 2023. So this has been months of work. We can't even count the amount of hours that she's put into it. So aside from those things, I think the other things that, just for your information that I'll add into this is, while we talk a lot about our naloxone and the vending machines and our harm reduction, they really are just one piece of the services that we're doing here at the health department in relation to trying to manage this overdose crisis. And so, one of the things that I really heard a lot about the board meeting during the board meeting is we should be sending this money to solutions. We should be focusing on recovery. We should be doing all of these other things. And as our representatives in those meetings, one of the things that I really want you all to know is that we're doing all that too. The solutions peer response team that you guys are hearing about, that's being funded by us. We pulled that grant. The health department was through OFR, which the health department is the backbone fiscal agent, the founder of OFR, so to speak. We supported all of the community conversations that were done to get the solutions peer response team started. And then we wrote a grant with the Bureau of Justice Administration to get the $1.3 million to fund the solutions peer response team. And so I think that gets lost in discussion quite a bit about the services of the health department, is that we want the vending machines so we can stop overdose in that moment, but we also want to make sure that we're supporting recovery and we're supporting treatment options and we're meeting people wherever they are at. I think our goal of our substance use services is to create as many doors and avenues as possible so we can prevent death and keep people safe and get them where they need to go.
I had spoken to the medical examiner this week, about overdose deaths. And she said in 2021, there were 41 confirmed overdose deaths. And she said that was the highest number, on record that they'd ever had. It was down a little bit in 22. In 23, because of course, obviously we don't know what 24 is. In 23, the overdose deaths confirmed are 45. So that's 4 more than what the highest was in 21. And there are 3 pending, which she expects will turn out to be. People on the county board who said this, why should we be, this is just helping people figure out whether they're taking safe drugs. If there are 5 people that somehow we help take better drugs, but we save the life of 1, what is that life worth? Isn't it worth it? I do not believe, first of all, that we're helping people be safe with their drugs. But let's say it is. For the 5 that we help, isn't that 1 life matter? It should matter, because that 1 life is somebody's child or mother or father. Those lives matter. And we can't just look at drug addiction as though this is a choice that people have made and they made a bad choice. And so they have to live with it. What have we become if we just decide that we're willing to sacrifice whatever over this addiction, which we know is in fact an illness? Addiction is an illness. However it started. And again, I don't understand. I'll never understand what kind of business practice it is that you add fentanyl, which will kill people, into drugs. Because it's like, if you're going to kill off your customers, what kind of business practice is that? I don't understand how fentanyl works into this and what the mindset is that we can lace things with that when you're going to kill them. Beyond that, we need to save lives. And there are at least 45 people, or possibly 48, in our county, our friends, our family, our citizens who'd be alive today if they'd had the help they needed. And I don't know how we can turn this down. I'm surprised that I was surprised the vote was as close as it was, that there were that many people on the county board who did not see a benefit to saving lives. What are we here for? What are we here for?
Supervisor Harrison.
Yes, go ahead.
So thank you, Supervisor Powers. I think the one other thing, as you were talking, that I recalled from the board is, so I think there's this myth that the Narcan kind of becomes like this party option that, people can use drugs and then Narcan and, it just keeps the party going. But the reality of Narcan is that for a person that needs to be revived with Narcan, that situation sucks. It is immediately stopping all of the opioids in that person's brain from being absorbed. And as it's been described to me, the best that I can like relate it all back to you is like, imagine you got hit in the head really, really, really hard with an object enough to give you a concussion and it knocked you out and then you woke back up, right? So you're going to feel nauseous and you're going to be in a lot of pain and really kind of going into withdrawal. So it isn't something that people are using for fun. It is a tool that doesn't feel good, but saves a life.
That's good. And what you guys are saying, great, but that's what I said in the beginning. We're on the same page of that. What I wanted to do is the fact that I got it is there was one vote off. And I know there'll be a second one because you'll have to convince somebody else. So you're looking at two people. So what I thought, the 5 or 6 things that we got out of it. There was one, they didn't think the executive should be on there. I got hit on that a couple of times, that he shouldn't be partnering with you. You should be making that decision. That was one area we could cross that off and I put that on if we wanted to. The next one was, I think, I'm not gonna say the names because I don't want to pick on it. But there was another one where they thought in Neenah, did you ever check with the mayor or something to see if they were okay with it? I heard that. And he was on the fence and because we hadn't, he didn't vote. That was one. That's another. The other one was where the machines were located. They kind of didn't want it because too many kids, but again, is there other places we can go? If Solutions is doing it other places, maybe we could join with them somewhere else. Again, I'm just trying to find, because it was real close. I know, pretty much about all the drug. I didn't hear that much about that. It was all about these little petty little things. And not petty because they're important to them. So I'm not gonna say that. But, and then I'll see what else was it. Check with the mayor. And then also, did we do any studies outside of that? I think there was one that said, did you check with Neenah about what they thought about it? And we didn't really do some of the stuff. They thought we should go deeper. There was 2 or 3 people would have been over if they just, we had an answer, we had done something, I think, for that. And the last one, which was for me that I didn't understand, is there was a lot of people in the crowd that were for it, 100%. I don't think anyone didn't want it. Even the coroner was there. But I didn't hear much from the sheriff. And there was a little afterwards when I talked, some people said, well, the sheriff isn't on board. Well, I didn't know
Actually, it
that.
got brought up. One of the supervisors, and I know
Yeah.
who it was, and he said,
Yeah.
well, for me, the sheriff is against this, and so I'm gonna be against it. I don't know why the sheriff would be against it. I don't know that he is.
And we didn't know that.
Yeah. And
So-
I was surprised when the supervisor said that, and, I don't know if that turned anybody's mind or not. But when the county executive gets up and says, my own brother was a drug addict and he's turned his life, I mean, you saved his brother's life. This is somebody you can actually identify and say, here's somebody, even if you don't know that brother, you know John, and it was important to John. I don't know how we turn this down. I really don't.
But I think if something in those 5 or something, if we can bring it, it has to be someone that turned it down, bringing it back. So we have to convince someone to go along with that.
Well,
Right? I'm sorry.
didn't a few county board meetings ago, didn't the assistant coroner make some comments about the scenes that they've been to where there was a death and they find the materials there that the health department has provided? And she was using that.
Wait, was that the coroner? Did that?
That's the assistant.
Or assistant
coroner,
coroner.
she-
It was Cheryl who mentioned that,
Yeah.
and what happened is before we went through the current way that it would be provided, is that there were needle syringes
Oh,
and the little cups
Cooker
that you
thing.
heat, the
Yeah.
cooking thing. And that was something that was addressed because those are no longer in the packet. Now,
Right.
apparently the state, and correct me if I'm wrong, please, the state says that the needle syringes and those
cooking vessels.
cooking vessels are not drug
Paraphernalia.
paraphernalia. And so that was why I believe they were put in originally, and that was what Cheryl's problem was with it. That was addressed
Okay.
and wasn't, those things are gone.
Okay.
Yeah.
And so what's in there? And we did actually open up one of the kits and show the supervisors
Yeah.
that it is a nasal spray. We discussed the fact that whoever took the overdose was not able to do it for themselves because they were unconscious. And these were the things that were addressed. I have certainly talked with a couple of the supervisors about this, and one of them said, well, what about the why? My district, the Y is across Commercial Street. Now, there is no child in childcare who's gonna be crossing Commercial Street to get to the vending machines. And if you are in childcare, when they are outside and playing, the park that they go to is in the opposite direction. So to me, it is irrelevant. Any child who's going to be around those vending machines, to me, does not have a great deal of parental support, because the health department in Neenah is in fact a very busy place. The parking lot is always full, but it's not kids that I see going in and going out. It's not. As far as, I've got all of these things written down, I did speak with the mayor. And she said that nobody had contacted her and she didn't know about them. And she does not have an opinion, but one of our supervisors talked with the Neenah chief of police, who suggested that we not have the vending machines. And so the chief of police in Neenah has reiterated that to the mayor. And that is how I understood the conversation I had on the phone with our mayor. And that says to me, we need to go about educating.
Yeah.
Boy, it really says to me, we need to have the knowledge. And I am so tickled we are doing this meeting monthly now, because we can start to learn about all of this information. Y'all are educating me hugely. I'm happy we've addressed the time frame. We've done that. I have an email from someone who was asked to approach me by another supervisor. And he said, I sent a proposal to the county executive as an alternative to the vending machine. And here we are. The community doesn't realize that these options are out there. And so again, we need to go about educating the community. I am disappointed that I did not get a response from the county executive. I would appreciate a talk to you. And then he sent me another email and he said, what about other dispensers, bathrooms, fem high products, and in the male bathroom condoms? Why can't we put them in those machines? And from what I'm understanding being said here today, that those things are out there. There are ways of getting it. The next thing is, lots of people said to me, hey, you know what? You've got somebody passed out and now you've got to call up and get a code to get into the thing. They're dead by the time you've done that. And I'm thinking to myself, well, no, if I'm going to be a good Girl Scout, if you're going to be a good Boy Scout, you might have this with you to take care of it if you come across somebody who is unconscious and you know it's because of a drug overdose. I would rather approach all of this from the front end rather than the rear end, but you know, we've got to touch kids. So there's that. Prescription options, sheriff. So there are two sheriffs that I have heard are not on board.
Well,
Next,
we only have one sheriff in the county. What do you
in
mean?
the county, the Neenah police.
Oh, police, okay,
Police.
not sheriff, okay, police, yes, okay.
All right. We're gonna go back to one of the supervisors said, where's the data? Oh, I am going to be talking about data in a little bit because I know that at the Spirit Fund, there was some discussion about it. And so the next thing I have to say is, what do we say to grandchildren? Turn on your listening ears. I wish our supervisors would put on their listening ears, because I found that many of us are really poor at hearing the discussion, and we have repetitive things coming up. And people haven't listened, and I think I'm done now. Thank you.
Thank you, Polly.
Oh,
I just got, oh, go ahead, go ahead.
I'm sorry, the other one is we haven't addressed the next drug that's out there on the streets.
That we haven't even seen yet.
No,
Hasn't
it
even been created
is. I
Oh.
think it is.
Oh, I'm
I think
sorry.
There's a
I thought you
new
were
drug out there,
okay.
Karen.
Are you talking about xylazine?
I think that's the one.
Our harm reduction program is providing xylazine education and xylazine test strips, similar to the fentanyl test strips. So we can help folks know what's in their substances, and we've been, encouraging them not to use if the xylazine is there. We are one of the first and only health departments in the state that are doing this much work around xylazine. So the educational materials that have been put together by our harm reduction specialists are being distributed throughout the state.
Thank you.
You're welcome.
Okay, sometime last night, I flipped on the television looking for something. I caught the tail end of, on Spectrum News 1, they did, I only caught part, they did a whole segment about those vending machines in 5 counties, I think, in Wisconsin. I intend to go back and look it up today when I get home. What was that whole news, that spot about on Spectrum News 1? And I hope it was only yesterday that was the first time it ran, but I can't guarantee it. And the other thing, I feel like I keep sort of griping about various board members, but it did amaze me, the sort of vindictiveness, because even the notion that how dare a drug addict get to be able to go to a vending machine and get a hat and a pair of gloves. I mean, the silly things that were said, and maybe to those supervisors, it wasn't silly, but why would that be an issue that they shouldn't be allowed to have a pair of warm gloves? They're probably not that warm, they're probably knit. Probably there's little ladies, little church ladies who are busy knitting hats and gloves. Why would we, how does that diminish us if a drug addict gets a hat or a glove? I don't get it.
Okay, well, I get your point. Hold on.
I was very disappointed after the last meeting, and you did a great job being there, and I think all of you have done a great job with that. I feel like all of you took that, the first draft and fine-tuned it really well, and I really thought it was perfect, and I thought there is no way we can go in this meeting and leave, and we didn't win, and then you go home that night and you're like, 5 hours, and how the heck did we lose that one?
Yeah.
And I mean this, like, it was played so perfect by all of you. And that was tough to deal with. And I think you want some people in the meeting. Some people did turn over from a no to a yes. But I just feel like there's this group of people that I just don't think we're gonna win. And I just let that group, that there was data, and you had, I heard 3 people say we value life. And I think that's what you were bringing up, and I don't think that mattered, honestly. I don't think the 3 times that 3 other people said it, it didn't really get through. So I don't think that is it's not a thing, is valuing life apparently. But I think that maybe we should go with the community partner avenue and maybe try something different, unless you guys want to, try to convince whoever else. I guess, I know we need 2 more, but maybe we should go with that other option so we can get it through faster. I guess that's how I would see it. If it didn't work with what we did, maybe try something else.
I think there are people, they are just, my mind is made up, don't confuse me with the facts. What are you gonna do?
Absolutely.
What are you gonna do?
Yeah. So that's just my opinion on that. And maybe you guys can go through that and see what that looks like. Unfortunately, that's the route we have to go, but that would be my suggestion.
Well, appreciate the talk. Good discussion. Go ahead.
Yeah, no, and I appreciate the feedback, and certainly want to hear more from you about the direction you feel is good. We are exploring those options. The money is for vending machine and for Narcan. I don't know that we can change that. That's what the grant application was for. This is, an evidence-based strategy. And And it's why the opportunity was put out there. Winnebago County decides that they don't want to use this as a strategy. We can't just do something else with the money. I mean, that's what it's for. There's a balance between how much work that we do and how much research we do and how many partners we work with, and educating, our staff and our partners, educating you and educating a 36-member board. There's a trust issue that exists here. We can't impart the level of knowledge that we've accumulated over months and years with our staff to the county board in a 5-minute, presentation or a 1-page handout. I mean, we could hit the highlights of that and make recommendations, but ultimately, if the board doesn't trust that we're acting in the best interests of our citizens and our county, we're gonna have a tough time getting something like that through. You mentioned a couple of things about the resolution. The county executive had his name on it because he felt like that was an assurance to the board that the health department, wasn't gonna make a decision about putting something in the vending machine that he thought the community wouldn't agree with. Despite, what evidence tells us and what we feel is best, it was a check for anything that, might be controversial, to slow us down, to share more information before we went ahead with putting something else in the vending machine. Our overdose fatality review team includes every police jurisdiction. There's 7 police jurisdictions in the county. Nina certainly has representation on the overdose fatality review team. No, we did not directly reach out to the mayor or police chief on putting a vending machine at the county health department. But we've had articles in the newspaper. We have police officers that are on the overdose fatality review team. We're not doing this in secret. And so, while we perhaps could have reached out to more people than we have, it's not that we haven't reached out to a lot of people and did this in a vacuum. What we heard about studies and data, frankly, we've given lots of information about the benefits of this. I think we all here, at least here, pretty much understand that this is one of many strategies that we're working on. And saying I still don't have enough information or enough data, it is, I think, just hiding behind not wanting to say why you don't want to do it.
Yeah.
I mean, you can Google in 15 seconds more information than, we've already presented to everyone. And so it's not that we're the first in the world to do this and there's no evidence for doing it. It's there. And so we're not going to change some minds on this no matter what we do. And we're at a point where we need to balance the level of effort that we're putting forth for an $80,000 grant. We have lots of other strategies going. We will keep going on this work. We'll keep working to try to enhance access. And we're just one of many community partners that are trying to address this. We're not doing this alone. And so in some respects, it's okay to move on. And for us to refocus our efforts in areas where, we can provide more community benefit. We'll definitely continue to explore the options of DHS. Hopefully we'll hear within the next week or two what it is that we can and can't do with that funding. And there's more opioid funding that's coming to the state, and that the state is, has a plan for how they're using their funds. We will try to leverage those funds the best that we can, in addition to the funds that come to the county. Most of the funds that are coming to the county right now are being put into the Direct Connect program, The county board has to approve the expenditure of all those opioid funds. So if you feel like there's a use for those funds besides the Connect program that you want to see these dollars used for, then you need to make that known, with the county executive and on the county board report. I don't have a breakdown of the budget of those funds for 2024, but we know that they're largely being put towards the Connect program, which is a great use, but there's only so much money. Ashley, do you want to add any more to that?
If I give you time,
Does it need to expire?
Well, that's what we asked, because we're nearing the end of, I mean, it was a 1-year grant cycle, as we're getting pretty close to the end. Because these are settlement funds, it sounds like DHS can be more flexible and they don't have to spend them within a certain period of time. And so we're waiting to hear back about how long we might be able to extend our use of those funds, or perhaps we could redirect those to another community partner and have them expend those funds.
And could another community, would that change the grant in any way? I mean, they granted it, the grant was issued to us for that particular thing, but can it be assigned to a different agency without any problem?
But that's what we're waiting to find out.
Oh, okay.
The question would be is if this is gonna be, if these funds, are to be used for vending machines, then where do we put them, right? If the problem is location, then we haven't really solved anything by giving them to a community partner. I mean, we've already worked, with our facilities department, our IT department, to establish these locations. You need locations that, are probably in a location where you have to have power, you have to have internet. They need to be secured. And as a part of planning for this grant,
Secured means what?
well, anchored down to a
Oh,
building
okay,
or whatever. As part of the planning for this grant, we approached a number of, and I don't know how many, but it was not easy to find locations where people were willing to have these machines installed and to assist us in maintaining them, that we could just move forward with that. That's why we chose location. One, Neenah was an important location for us because we don't have access up on the north end of the county. And it has to be a location where, we can effectively monitor it, refill those machines, and, really have an eye on them. It'd be great if another community partner was available and wanted to do that, but I'm not sure that we're gonna readily find another location, where somebody's willing to take on that commitment.
Thank you for all that. I mean, what you just said is convincing that we didn't have before, honest. But you just said that whole thing. I still say it's so close with one or two people that I know there's some that if we answered it just like we did in some of those facts, it'd be over. So that's my opinion, but we'll go on. I just wanted to spend time because I think it's important
Yeah.
that it was so close. It's not something we should let go. That's my opinion. Okay?
Well, I'm curious, what has to happen in order for that to come up before the county board again? What
One
kind
of
of
the-
process is that?
Somebody that voted it down has to bring it back. And I think there, again, from just talking to a few, there was a couple, three, that if certain things are changed, I think they will. I mean, I'm not badgering them because they have their own opinion, I'll have their own opinion, but seemed like minor things that we had information more like, if you just told me you tried everything else, I didn't hear that before, and they don't give you a lot of time to talk up there, do they? But as we could be faster to ask that, if maybe you took John off of that, took that'd be another area that might be, there's so many little ones, and I know you want to spend a lot of time, but you did spend a lot of time. When you look at April, I mean, I said that to board, April, it took them 8 months ago, they were done this. We went through 2 different boards, they tweaked it, pulled it, everybody's asking why you keep pulling, because they're tweaking it. They were tweaking it to make it right, and that's why it was so close. Because I know the first back and forth, there was a couple people that weren't gonna, and then they finally went. And there was 2 people that were on the edge, that would have gone either way, but I don't know what happened. So that's why I said so close to give up on it. And I know we can go on, I mean, I'm not saying that, but it just was just some minor things that if we talk to some of those people again, we might be able to bring it back or get them the response to the bill and then try a resolution. Okay.
I just want to say that I was very disappointed. I think Ashley knows about how disappointed I was.
And we are, I mean, that's why I said I'm all the same agreement, this is, how can we do it? And that's all I wanted, I didn't want to get on anybody, I just want to see what could we do with those little things and maybe make it better, give you suggestions, and I know you've worked on some other stuff, so. I didn't want to spend a lot of time in it, because we're trying to keep our meetings down to 6 hours instead of 5, right? Or whatever, no. She's failing right now. No, that's okay. We like discussion, so that's, I do, these guys seem to, yeah. Okay, so go on to D. Discuss community health needs assessment. That's Heidi, right?
Yeah.
Come back, okay.
And there is a handout, Pam and Karen, have you all picked that up? It's a summary of the community health
I
assessment.
see this that I don't have, and this you're talking about.
Yeah.
Yeah.
Is anybody, who else needs one of these?
Anybody else? Okay. Um,
Thank you.
so at last month's meeting, I went, basically over the process. And you did, we presented you with the full report. It's about 60 pages. And so, but we didn't really get into, what was in the report. So that's what I was just gonna go over today. And so I just, this is a team effort. And so we had an internal team as well as an advisory team. So you can see the internal team members, myself, Susan Garcia Franz. She is a community health strategist. Sarah Jean Schuckerman is an epidemiologist. Maddie Brager is also a community health strategist, as is Danielle Florence. And then Kevin Kropp was a student intern. So those are our internal team.
I see they have closed captioning on. Do you want that?
Bob, or something?
Yes, we do.
Okay.
So this is just a, review of what the community health assessment is. First, it's a requirement for local health departments to complete at least every 5 years. And so later this year in 2024, we have a review with the Department of Health Services that's called the 140 review. And so, and we have to submit our community health assessment. It's a collaborative community process. And so we collect lots of different data and information. And it's about the health status of the community, challenges and assets. And then also it's the interpretation of the data. And it's, it's to inform other plans as, for decision-making. The community health assessment, do you need one of these?
No, okay. My summary that we had out last month. This was.
Yeah, that's the full one. I've got in my name. Thank you. Yeah. So one of the goals is to have it easily understood by the stakeholders and the audience, which is our community members. So that's, what we were trying to do with this. So again, like those 3 goals that we're working on is involve the community. So we formed a community advisory team and we wanted to lift up voices from the community, from people disproportionately impacted. And so we collected information, we held focus groups, and we talked about with the community advisory team, what populations we wanted to talk to. So people experiencing homelessness, people experiencing food insecurity, people of color, refugees and immigrants. And it's not an exhaustive list. That's who we were able to talk to in the time frame. The other goal was really this idea of challenging the idea about health being this that it's based on your individual choice, that if you just make good choices, that you'll be healthy. But really health it's more complex than that. And it's really impacted on where we live, learn, work, and play. There's a lot of factors at play that influence a person's health. So we wanted to really talk about that. And then we wanted to make it easy to read, use plain language and more visuals. So the model that we use, this comes from County Health Rankings, which is a program at UW-Madison, the Population Health Institute. They do counties across the United States, and they have a set of indicators. So we can look at it for Winnebago County, as well as say, there's Dane County, there's Miami, Dade County in Florida. You can look at any county in the United States. And they have a model that, what influences health outcomes. So the length of life and your quality of life, and they have that broken down. And so really, when it comes to health, your zip code matters more than your genetic code. And so what that means is that when you look at like the social and economic factors, at 40% is how it contributes to those health outcomes. the physical environment, which is like, you know, the quality of the air and water quality, the built environment, which is like housing and transportation, that's 10%. So we add those two together, that's 50%. Clinical care, you know, that's access to care. And so if you're able to afford care and have the care that you need, as well as the quality of care, it's 20% that contributes to those health outcomes. So right there, that's 70% that contributes to health outcomes. And health behaviors, while they do play a role, it's about 30%. So that's like that idea that it's, you know, these other factors have a really big role in your health. We also use the Healthy People 2030, which is healthy, it's part of the Health and Human Services.gov, part of the federal government. And so they have these 5 categories that, and we've been calling them community conditions. So it's the economic stability, neighborhood and built environment, education, access and quality, the social and community context, and then the healthcare access. So we organize the report around those categories. So, and then also part of the requirements is that we include information about the demographics. So, in gray, this graph shows youth, and then the orange is adults. And so you can see that our younger population is more diverse. So that's really evident in the schools in our county. And also, you know, when we look at our age, you know, our population is aging, and we've known that for a while. So just to, you know, highlight some of these key findings, our median income in Winnebago County is almost $64,000. This is median household income. We did look at it, so there's more information in the full report, but we did look at compared to surrounding counties, and Winnebago County has the lowest median income. And there's MIT has a calculator for living wage. So they've calculated living wage for counties across the United States. And so when you can put in some different data points, but so for a family of 4, a living wage would be just over $100,000. And that would be, so you wouldn't get any support from, you know, that's if you're completely able to cover everything on your own. You know, a lot of people get support from parents, from, you know, friends, from family members, as well as getting support from government or other government programs, social services, that kind of thing. So, that's kind of a lot, you know, you think of a family of 4, right? Of, that's what it is to live here in Winnebago County. And then when we do the breakdown of what households make, you know, that only 27% earn more than $100,000. And our highest number is under $50,000. And so these are households. They're not all families of 4 there, but it just, you know, it puts things in perspective a little bit. And I think the next slide.
Those are, if there's 2 people working, they kind of take that into account too?
Yes.
Okay.
Yes. But what we're seeing, you know, is that people have been struggling with basic needs, you know, and why is that? And this data is coming from the United Way ALICE report, which ALICE is an acronym that stands for Asset Limited Income Constrained Employed. So it's people that are working and they still struggle to cover basic needs. So we found that 1 in 3 households in the county struggle to cover the basic needs. There's, you know, from this 14-year period from 2007 to 2021, this shows the percent increase in these basic needs, the cost. And, how much everything has gone up and, really wages hasn't kept up as much as what the other costs for, just basic needs, childcare, healthcare increase in 15 years, 59%. It's huge. We also looked at, we're able to look at disaggregated data, so breaking it down by race and ethnicity. And, in more recent years, we've been able to get more disaggregated data. So we can see, and this is, trending over time, the differences in median income by race and ethnicity. And you can see that, the blacks in our county have historically, over time, have considerably lower median income. And then also that, the poverty, but the children experiencing poverty in Winnebago County is the Black children are disproportionately impacted there as well. So, some of this, like I said, we've, in the last maybe 5 years, we've been able to get more disaggregated data and helps us to better understand the conditions of our county. Around housing, so it is, this graph on the right here, the housing and shelter, this data is from the United Way 211, and so people can call in and they, housing and shelter is the #1 request. Much more than the other, like, #2 is healthcare and COVID. And that housing is, people struggle with finding affordable housing. We're also able to look at the number of evictions and how much, that can be a problem for people. So during our focus groups and what we've heard people say around housing, some people are working full time and still cannot find affordable housing. And, this is happening across the nation, that the cost of housing is increasing. If a renter does not have their documents, immigration documents, landlords have charged double rent. If somebody does have an eviction on their record, that can be a real obstacle for, acquiring housing, stable housing. Some people, they don't even know that they've been evicted, and then, to get a new place, you have to go through a credit check or something like that, and then the eviction will show up. If somebody has a felony, it's very difficult to find a place to rent. And then there's also a fear among renters that if they complain to the landlord, that they will, about any of the housing conditions, to ask for improvements or something like that.
Is that a legitimate fear? Does that happen?
Yeah.
Okay.
And this is coming from.
But it's not just a fear, it really happens. Yes.
Yeah, it's right. So they're afraid to ask for, that conditions in the rental unit are fixed or addressed, that they'll get evicted, or they'll get, yeah.
Okay.
They'll raise the rent or they'll get evicted. Educational access and quality. So this looks at third graders who can read at grade level or above by the different school districts in the county. So this is an important indicator because, until you can see that until the end of third grade, most students are learning to read. And then in fourth grade, students begin reading to learn. So they, up until the third grade, you're learning how to read. And then, fourth grade and beyond, then you have to be able to comprehend. So for students, and school becomes much more difficult than at that point for students who struggle to read.
Is there any indication about, look at Winnebago, Winnebago County rather. It's twice what Oshkosh, what are they doing right in Winnebago County, or what are we doing wrong in Oshkosh? Do you have any idea?
There's a lot of factors.
Zip code.
You know, it's like, you know, where you live, what your family income is, what access to resources you have, how much engagement you have in the development of children. There's a lot of reasons. And I mean, there's a reason Heidi started with income. You know, income is probably the single biggest correlate to health. If you don't have enough money to make basic needs, education is hardly the priority. It's survival. You know, it's staying in a house. It's, you know, money for the next meal, which may not be as nutritious because you don't have a lot of money. It's the chronic stress that exists in households when you don't have enough money to make ends meet. And then with that kind of chronic stress, you know, comes not ideal conditions within a household. I mean, you're more likely to see, you know, less engagement of the kids. There may be domestic violence, maybe all kinds of issues that arise, you know, from that stressful situation. And so, you know, where you live, how much you make, what those resources are that are available to you really matters.
To know what you're doing, I see people taking pictures, but it's in here. Some of those things are up on the screen, right? They're all-
Yeah.
So just so you know, I didn't watch it.
Yeah.
Had to do extra stuff. We didn't need to, so.
About 30% of our residents have a bachelor's degree or postgraduate degree. And so it's just a little lower than the state average, which is 33%. We've also been able to look at disparities among people who have a bachelor's degree or higher. And cost is and academic preparation are the top barriers to college access and success. That's in social and community context, that section we go into, you know, that idea of social connectedness and belonging, which is really this, you know, basic human need. And it's about being connected to other people, to the physical places where we live, and experiences, whether, you know, individual and collective experiences. And I will say, so we did look at assets, you know, we know that data can be kind of, you know, depressing a little bit. We also asked about why, you know, what people like about living here. And there are a lot of things. And they like the parks, they like the natural resources, the lakes, the community, the small town community feel, the safety, their neighbors, the libraries, the services, the doctors, the care that people have for one another. So there's positive things as well about living here. But, you know, so anyway, looking at data from the Youth Risk Behavior Survey, which is something that middle school and high school kids complete. It's an anonymous survey. That students who identify as lesbian, gay, bisexual, transgender do not feel like they belong at school compared to 31% of straight students. So it's really, again, another disparity there. And then in general of, you know, for middle school in yellow, high school students in gray, the students did not feel like they belong. So you can compare there. So it's higher among females than males. Takeaway there. We did ask people in focus groups about racism and discrimination and what they experience. And so here's just one example. Person of color said, you know, the neighbors call the police on the kids when they're just playing outside with each other and being kids. It makes me uncomfortable, especially as kids get older. So they, you know, this happens here. To the next category around healthcare access and quality. What we heard that there are often long waiting periods to get an appointment, especially for mental health and also for dentists. There's a lack of diverse and culturally responsive care among mental health providers. And then only 1 in 7 Medicaid recipients receive preventative dental services. And that's because there's not that many dentists in Winnebago County that accept Medicaid.
Is that because Medicaid is grossly under funding preventive dental? Okay. I'm seeing, somebody nodding, okay.
Tri-County Dental.
Yep.
And I was speaking with someone just recently about who's just getting on board and saying that they are going to come up with their data, number one, and they have got any number of the dentists who are volunteering their time to be there. And I guess they just need to do a better job of letting the community know that they're there.
I think they're really busy.
There.
Yeah.
Yeah.
That's,
Yeah, and I think another thing to notice, I mean, when, you know, if you have insurance and you go to the dentist, you have one dentist and you would have multiple dentists that are doing preventive things. You go to Tri-County Dental, you go to Partnership Dental, you have lots of dentists and few hygienists because they're dealing with issues that go way beyond prevention at that point. They're having to fix problems. And so we, you know, that's like way later than we want people to have dental care because they're only going there now because they have a problem with fix that they just can't bear with anymore. And that's why we have, so there's so many dentists there and not hygienists.
thank you. That makes sense.
Health outcomes, you know, so this is looking at the top causes of death in the county, from data from 2020. We do have, you know, more recent data from overdose deaths, from all the work with OFR and, that kind of thing. So, and then we can compare it to the state. And then, life expectancy. So, this, you know, overall, you know, we can see that we're at 79 years. But then when you break it out by race and ethnicity, Black population has the lowest life expectancy. And then for the data around heart disease, by race and ethnicity, age 35 to 64, so premature death.
Heidi, but especially with the economic impact of, you know, children who are including poverty with this life expectancy. An important demographic that's not for Wisconsin, that's not on here, or what about the native population? Where are native children in terms of experiencing poverty? Where are they in life expectancy? Where are they in health? Why is it we never look at the native population? Because there's not natives throughout the nation, and that's so we don't care. But Wisconsin, Michigan, these native populations are big. They're
right. It's has to do with the number of in our county. So we have a low number
in Winnebago County. So other counties
Have higher.
would include them in there. Okay, all right.
Yeah, and if we were looking at state data, we would definitely do that there.
Okay,
But Winnebago County, the population of Native Americans is very full.
okay, thank you.
This.
I'm sorry.
So I just wanted to say one thing about life expectancy, because we can look at it, you know, in our county and we can compare it to the state, and then we can look at it compared to other states and that kind of thing. But in the United States is number 40 in life expectancy. So that means there's 40 countries that have higher life expectancy than the United States. So we're not just talking about a few in Europe or something like that. There's on 6 other continents, there's countries with higher life expectancy. And so, and this is for the United States, this data is true across age brackets, racial demographics, and income levels. So if you live in the United States, you have a lower life expectancy. And to me, it's unbelievable, really. And so people tend to blame, you know, individual lifestyle choices, but the research has told a different story, and that the United States lags behind in policies and programs that lead to long and healthy lives. And so, you know, public health, we're in the business of health outcomes. And so, you know, but then we go upstream in order to improve, you know, for people to live long and healthy lives. And so, you know, our country, just, we don't do very well in the policies and programs that really support healthy and long lives.
It seems goofy because I'm just thinking that my parents, they didn't live that long, I mean, some people, some of my friends, they're, when they get to 50, they're worried because their relatives all died before 50, way back when. And we're doing more things. Technically
Absolutely.
you think
So
now.
when you look at public health over the long haul, like, life expectancy, increasing life expectancy has been an incredible success story for, public health type of interventions. The thing is that it's been slipping. So we did, it's been declining because of, a lot of the struggles that we have. There's there's what's been called the deaths of despair. So it relates to the overdoses, the opioid epidemic and crisis, which is, it's a massive crisis across the United States. The deaths related to alcohol, and then suicides that, that across the United States as well as our county has, experienced that kind of thing. So how do we improve community health? And, we have to invest. I mean, healthy people are a result of healthy communities, and we really have to be intentional about the programs and policies that we want to see. But there's lots of evidence out there that there's programs and policies that work. And so also we've been talking about this, how we collaborate with our partners, and so to maximize efforts. Focusing on areas of the greatest need. So, that's by looking at who has the greatest need in our county. And so when we, disaggregate and like really go into that data and understand it and pull it apart and see what it says, we have disparities in this county. So the next steps is to share this report with the community. It's now on our website. We use the information in the community health assessment to determine our community health priorities. And then, so that's our next project that we're working on internally and also with the community advisory group, to identify those priorities and then write a plan that includes goals and strategies. That's it. Yeah.
It poses the question now when I'm thinking the blacks probably don't get to see a lot of this. I mean, they don't have a lot of ability, their income, they don't have a lot, they don't have time to go look at a lot of this stuff. So how do we get to them?
We have team members on the advisory committee that are part, that are Black, that work with, Black community, and, so they've been able to contribute to this, and then we will share the report with them. And
on the flip side, again, if I was a Black person and I saw this report, I'd say, you guys aren't taking care of me. You're doing everybody else. I mean, that, some of them will say, you're not taking care of me, you take care of everybody else. And your report says that. How do you get over that too? I mean, they gotta feel, probably all the different groups probably feel they're being left out. How do I get, how do you reverse that education-wise? No, that I understand, that's for the past. How do we change that? Change it, educate, right?
It's about information like this, it's about being intentional about disaggregating the data. It's being intentional about looking what our current policies and programs are that we have in place that may unintentionally negatively impact some populations. It's about developing policies that are intentional, that when we develop new policies, we look at those policies for those intended consequences. And it's the whole discussion about equity and equality, right? I mean, there are programs that are great for the entire population. And then there are programs that really target those that need help the most. And so being intentional about that, and speaking out on that. I mean, when you if you apply a program that 90% of the population doesn't need and you apply it across the entire population, you're wasting a lot of effort and resources. If you could target that intervention towards those that actually needed it the most, you'd realize the most gain, from that. And so you have to see the data, you have to be intentional about it. And we have to sometimes have some difficult conversations about applying resources where they're needed the most, as opposed to applying resources for everyone. We got here through policies and activities that we've put into place over decades and generations. And it's gonna take time. We've created a lot of these situations where we have disadvantaged some populations in the past, and that has carried forward, and we see the results and outcomes of health length and health quality as a result of that.
When we look at the nation, our country being 40th in the world in terms of health, there are things that are so systemic in the fact that we encourage so much gun ownership, which impacts the life expectancy of an American. And in 1994, I was involved in some a year-long monthly health-related conference. And the one that was announced, I remember what month it was. The next one that we were going to be listening was the number one health issue facing with American women today. And so we were all kind of guessing what it'd be. As it turned out, it happened right after Nicole Brown Simpson was murdered, and the number one issue for women is domestic violence. And that's more rampant, I suppose, in this country than it is in others, as well. Not that she was killed with a gun, but gun ownership is another reason why women are at such risk. And the fact that we don't have universal health care, which a lot of countries do have. And if we're not going to support universal health care, then it seems like we really have to support public health to take care of the things that our insurance is not doing. The lack of insurance. Off my soapbox, sorry.
Okay, you want to?
Yes, please. And my question is it money related? I know that in education, they're spending a huge amount of money per student to end up with the results going down. And so I wonder if it is the money that's the cause or not of some of this. And of course, I go back to education and literacy. That's a huge thing for me.
One of the
literacy.
One of the best payoffs is investing in early care and early education, early childhood education. And that's where, we've seen that we've been having a child care crisis, things like universal pre-K, that just pays dividends, it's one of the biggest, return on investments that there is. But if families, but we don't have that, and families struggle with the cost of childcare and early care, and then you have to make really difficult choices. So these are decisions that, these are policy decisions that are, sometimes they're at the local level, sometimes they're at the state level, sometimes they're at the federal level. But yeah, when we don't have those policies in place, that we're all expected to, take care of it on our own, these are the, we don't have the best results.
Yeah, income matters, we're looking at things at the population level, let's compare education to healthcare, right? Most advanced healthcare system in the world, but we have really poor outcomes, right? Because there's a lot of people that don't have access. With education, we can have excellent schools, and we do, and by and large, have excellent schools. But if families are, having to work 2 or 3 jobs to make ends meet, that means they're not spending time with their kids. If kids aren't getting read to at a young age, or have access to books, or you know, they can't stay in school. You know, they're taking a job in high school to help support the family. There's are a lot of implications of income. And not only does that, you know, it really impacts in early childhood because, as Heidi explained, you reach a threshold where if you're behind, you're just behind, you know? And if you look at, you know, at an older age, when you look at the, like, say, going into university, if you look, when you break down what students go to what schools and you look at ACT scores, I mean, you can just graph it right out with income. The richest families have the highest ACT scores, get into the, you know, most elite colleges, right? And because it's income, because they have time, resources, you know, ability to, you know, foster that growth from a very young age. And so it's certainly at an individual family level, can you help mitigate the negative impacts of low income? Absolutely. But at a population level, you just don't see it.
Okay, and I'm referring more to the dollars that we spend on education per student to see the outcomes, not an individual family per se, but seeing that, I'm sorry, Neenah, Wisconsin is not having literate kids come out of school. I moved up here 35 years ago and found out that this was the second state in the nation for education. What? Excuse me, their letters going through my head right now, and I'm not gonna say what they are, but it does make you wonder. It is a lot of it because I've been talking to educators recently, and one of them said, I've got kids who cannot even read at the first grade level, and she's teaching fourth graders. And she said, it's really disruptive. How do I go about teaching, particularly in 15-minute increments?
Well, we pay for public schooling, why don't we pay for public childcare?
Oh, yeah. Well,
When we need to start intervening.
part of that is happening because they've now got K4 and K3. But then
Who's
you've
got-
got from birth to 3.
And you look at our policies related to how schools are funded, right? I mean, how do we support school districts with local taxes, right? So where you live matters. If you're in a community with high income, you spend a lot more money on schools than you do in a community with a low income. The resources aren't there.
I'm sorry, Doug, I live in Neenah, Wisconsin.
Right, there should be no.
It should be better than that.
Should be, yeah. Well, that's very interesting stuff. I appreciate that. The only question I'm sorry, you have a question right there?
It's a little depressing to think that we're working to start not getting very far this year.
Yeah,
Okay.
correct.
No, go ahead.
Clarification question. So does this report replace the one we got last month?
It's just shorter. Basically, it kind of gets some of the, you know, high points or just some of it's, so it's, if somebody's not gonna read the full 60, we have the categories and just we're able to, you know, take some things that were.
And will this be for general distribution and reading?
It already is.
Okay. Just an opinion, but I read last month's, and I didn't understand that you read this, and it's community health assessment. I thought it was gonna be a health assessment about the entire community, which it is, but in the goals, it's focused on looking at the disadvantaged, underserved, underprivileged, and I get that. And that comes across very strongly in the report. I want to make sure perception, it's respected. You know what I'm saying? I really want to make sure that people read this and understand it, that there was a focus on that. It's not, because the majority of the residents don't fall into a lot of the categories that are presented here. All I'm saying is I want this report to be accepted and respected and not just discarded as something that's something not about them. And I guess that's my only,
The backlash against calling out the
yeah,
disparities.
calling out all those disparities is. Yeah, I just, it's.
Yeah,
it's
I mean,
tough.
I think, one of the best practices that is in, that we follow in, public health is that when you're doing an assessment, that you look at the disparities among the subpopulations in your jurisdiction. And when we don't look at that, when we don't break it down, it seems like, oh, everyone's doing great.
I'm not arguing about
Yeah.
the process, I'm more about the communication, because the first paragraph here, it just says that implement a community health improvement plan to address the priorities of those who live there.
We don't have the priorities yet,
Yeah.
right?
And so, but reading that, then reading this tells me these are all the priorities. I'm not saying they shouldn't be.
They're not the priorities, they're just the data.
Yeah.
We have to determine the priorities. But, yeah, I mean,
Yeah,
Much like
I
the
appreciate
first
your-
step.
yeah, thanks.
Worry about it. I want it to be,
It's a balance that's hard to strike sometimes. The thing, this is a snapshot of how where our community's at. And hopefully it provides information and creates opportunities for those policies and programs. It's not meant to be bashing or, but if we don't have the data, we don't see the data, then it's hard to implement targeted initiatives that address it.
you said, right, I mean, then we are targeting these.
We serve, our community will benefit more overall when we apply our limited resources to where they make the most difference. And that doesn't always resonate well with a lot of people, because it's like, hey, wait a minute, that's my money, those are my tax dollars. I want those to serve me, but I don't think people, when you really look at what a successful community looks like, and the best way to improve a community is to address where those funds can go the furthest, that I can really raise. When we lift a community, we don't pull it from the top, we lift it from the bottom, and that's where the differences that we make. And so when we, help those that are most disadvantaged, most in need, most negatively impacted, then we really improve the overall community dependence on needs. We improve self-sufficiency, which reduces dependency on other programs. We improve community safety. We improve the success of families. And that's hard sometimes to convey in a way where people are like, yeah, our community will be better. I will live in a safer, more productive community if we apply those resources in those targeted ways.
If you could condense what you just said as intro to this, I think that would.
Okay.
And in relation to what you just said, all I see is negative. I don't see any of the positive. I don't see anything about what the community suggested was the positive aspects of it.
I think that's in the full report more, the assets. They were like the thumbs up, and we were able to highlight some of those, that we do have a lot of community assets. People work together. We have community partnerships, we're strong partnerships. People like living here. And this isn't, this isn't meant to be like a marketing, right? Like, it's to be used to understand where we need to address our priority, how we can improve health of the community. So it's not like it's not meant to serve as a marketing tool for the town. It's used, it's to be used to look at how do we improve the health of the community. And so we have to look at the things that impact health.
There's that priority word again. Right.
There's a meme I've seen on Facebook and stuff where women who are carrying water jugs on their heads and stuff, and it says, if hard work was a guarantee, something like if hard work was a guarantee of wealth, African women would be the wealthiest group of people in the world. And I realized looking at this table, we all won the sperm lottery. I mean, the children in experiencing poverty in Winnebago County, 9% are white. Look at us. We really did win the sperm lottery. I mean, we could have been just as easily have ended up, one of these women carrying jugs on our head in Africa.
And probably a lot happier, Karen, the jugs on our head.
Oh, I didn't take that out of there, but okay.
I just, I look at this and I think, people who think somehow, if there was just a better work ethic or, that's not the case. They're just, they're facing income disparities that we as white America and white Winnebago can't relate to.
Well, thank you very much. That's really great information for us. Anybody else have any questions before we go on to the next? Anything you want to say? No, you're okay. You're taking it all in. Okay. All right. Well,
I'm afraid what I might say if I.
all right. Next, Director. Oh, I'm sorry.
Yeah, I'm not quite sure where we have, our comments, but I was at a Spirit Fund meeting and it was right here in this room and Doug was sitting back there and I was sitting here and he's got this guy sitting next to him. And we were talking about data. And there was data being brought forward as far as getting the Spirit Fund to help fund getting data between 3 counties, as I understand it. And I have asked Doug to please speak with that gentleman who was here to talk about the DEX program, to come by and explain that to us, give us the pros and cons of it. Is it going to help that? And I think Allegheny County has it now. I think there are a couple of communities that have it and we were going to work with those. And the data from those 3 counties was going to be collected, as I understand what was being asked.
Can I interrupt for just 1 second? Just so we get everybody else in there. Ours would be down in the Board of Health reports. That would be kind of a what we talk about.
Okay,
Just
thank
so
you
that-
guys
is
for the
that-
next meeting.
I'd be respectful. Is that?
No.
Just so they can go through.
Well, we're coming up with the next meeting
Yeah.
already.
No.
Thank you.
I just
Thank
wanted
you.
to make sure. Okay.
And
This way you do that because you're very for.
rearrange the agenda to put director and staff updates at the end, so to allow more time for discussion. Appreciate that recommendation from the board. And to be respectful of time, our intent here is to try to get you out of here by roughly 9:30 on most meetings, since we're meeting every month now. So I would just, we'll get you some written updates on our reports from our programs, unless there's something critical that our supervisors need to bring up today. We'll get you a written report, update for that, just to save time. And your next item, Ralph, is the next meeting, and I made it here on the agenda.
And I respect your time. I know you guys are here, waiting here, and like probably the last 2 or 3 meetings, we had more discussion, which is something we've done a little bit different than the past. So really, I don't want to cut the reports out, or if we, I just suggest that if we did it, like had half do a report one time and then half the other half, then you're a month behind anyway, just so respect your time, because I know you guys got things to do in that, and then to keep our time on it. So. And I didn't mean to interrupt you, as I just want to make sure, because they've been there for us.
And if they ask our next meeting and
Okay.
one of my problems is I don't look to the next spot.
That's okay.
So anyway, Doug and I spoke about this data information. And I was saying, bring it up at the March meeting because I'd be here. One does not know if I will be at the April meeting because of the election. And so we discussed it. I am not going to be at the February meeting, but I will absolutely be online at the February meeting. And so we discussed having this gentleman come and speak at that meeting. So that was what I wanted to say. And I want to say thank you, Doug, very much for working with me on this because I'm hearing this word data over and over and over again. And in our family, there's a fellow called Thomas Sowell. And he believes that data is the important thing, and then being aware of the consequences of that data. How is it going to affect us further down the road?
Back to what Doug said, that was the wrong date.
Yes.
16th, 23rd is our next meeting.
Oh, I just changed it because I thought, oh, I got the wrong date.
No, it's because we went changed from every month. And gonna back up 1 second. The county board, when you get me, are you guys gonna put this assessment on their desk? Because I mean, that's us 3 or 4. But okay, yeah, or you're not. Because I think it'd be an idea for them to know this assessment that you had. Give them a copy. I know they pass out tons of stuff. We get at every meeting, but you know, again, trying to get all that information more out. We can convey it, but they should know about it too, right? I mean, is that an idea?
And how do you suggest, considering Toby's concern about, people not knowing the context or the purpose? Do you have any suggestions?
So, yeah, so we can try to address that. I mean, we can, preface mode, we could, maybe write a preface and edit in or something like that. You're the first group that we've shared the information with, and so your feedback is really valuable in helping us move it forward.
Because in the time that I've been here, what I see the most is, these resolutions go up there. They ask you to come up and speak, and it's kind of I want to say like a defensive area because, they're trying to pick things apart. And I love what you do, but you seem to be more personable and have a lot more information saying here, and then there you try and, okay, yes and no question. But there's a lot more that we got out of this that would convince me of a lot of different things for what you did. Well, it's okay. I just said the stuff you did the last 2 times, it really adds a lot to it. And they don't give you that chance in the meeting. They bring you up and then you're defending yes or no. Did you do this or not? It's like a courtroom. But I mean,
yeah, we're really
forget that sometimes when you come up and if we have to, we'll take one of us board members and one of us that are on the board and we'll ask you the questions, forget them. And then talk about it because to me, your personality, what you talk about and what you bring out is a lot more information here. I mean, that's just my feeling that I learned a lot. We all learned a lot about stuff that we didn't know. And are you raising your hand? I'm sorry. I didn't know if you were raising your hand. I feel bad like that, but I just wanted to make that comment.
And my concern with getting this portion, the smaller portion of it, is that that's a lot of information. And I'm wondering if it can even be sized down.
You just did that, right? You just did that in the big.
I think it's important that we go about letting the board know about this. I do.
Yeah.
But I also say how many people are gonna read it and how much of it's gonna get thrown out.
I think the thing is, it could be sized down, but the good thing about this is that there are these graphs, these wonderful graphs that you look at. You don't have to read all the words when you look at this and look at, child poverty in our county. There's a graph right here that's so easy to understand without having a whole lot of words. I don't know the only way you could size it down is taking all the graphs, and then you'd have something very dry to look at, whereas this is, buy your books, and all you want to do is look at the pictures. The pictures are important.
It makes me say, Nina, are you kidding me?
Yeah, but if you did it like Toby had talked about, if you do it steps, if you did a little note from the health department, that this is the first step, acknowledging what we have. We have other steps to go. And if you said you did a lot of consultants or you had a lot of extra help in the big one, the bigger one you had. It's all about that. And then this is the first step. And now there's more to come. So it's not like, that's it. We found out everything is bad. No, there's more, right? I mean, that's kind of what you were thinking. And if you did something about that.
Yeah, we'll look at writing some kind of a preface to, or note to the reader or whatever about this. Or it's also our intent to, hopefully address this in bite-sized chunks throughout the year. And so we've talked about picking a topic, a month, generating, social media posts on it, some additional information where we just talk about one thing that's in this report because there's so much here. And so we can use this to help us develop, these monthly topics or bite-sized, reports to educate educate as we go. And we can plan on doing that.
One of the things I am really appreciative of are the emails that you're sending us, that you're getting from the state. Come on, TV was essentially eradicated. Oh, wait a minute, maybe not. And so that was one of the things that I saw that sort of said, it's like heads up a little bit, this is important stuff.
We're gonna jump back over to 7, which we kind of, you got any more reports for me?
Well, is there a director of staff update?
We're gonna skip that and we'll get
Okay.
to it.
Okay.
Oh, the board updates, anything you have, that you want to bring up, other than what you did with it? Here's where you get.
Ralph, remember, I'm.
I know, that's why I said, this, okay.
I have nothing else to add.
And he's gone, and I just appreciate the conversation, and talking about stuff, it's kind of interesting, and the more we learn, the better we're, as ambassadors.
The better we are at defending you.
Toby, do you have anything you want to put in? Lois, anything? You haven't seen you for a while, anything you want to put in? Okay, all right, do I hear a motion? Sure.
So moved.
Second.
All in favor?
Aye.
Aye, thank you, everyone, appreciate it, okay, we're adjourned.